Hello, I'm Elisa Perigo. I'm a patient and a researcher, and I'm here to say a couple of words about the birth of long COVID and why long COVID matters. Long COVID is a patient-made term. Patient created long COVID. Long COVID describes a longer and more complex course of illness than that which was coming out from early report from China and policymakers at the beginning of the pandemic. And last winter and last spring, thousands and thousands of people were falling ill with COVID-19. They were not recovering, and they were left at home, sometimes to die with no medical care. So they started to come together on social media to share their experiences. They started to speak to newspaper, broadcast media. They started a grassroots campaign for recognition. They started their own research reports. In these early findings from patient researchers are now being replicated in biomedical research. Long COVID came into being as a Twitter hashtag in May 2020, and soon it became quite popular, not just among patients, but also among the media, medical professionals, and policymakers. And only 3 months after its appearance on social media, long COVID was used in the landmark meeting between advocates and the World Health Organization of the 21st of August, which recognized the long-term effects of COVID-19. But long COVID is not a single organization, a single person, a single nation, a single research group. It is a grassroots movement of people who came together in solidarity to ask and to provide for care, recognition, research. We really need to keep using long COVID. Long COVID is a testament to those who fought for it, even when they didn't know if they were going to die or to live. It is a testament to patient activism and agency. It's really good to bring attention to the sometimes devastating long-term effects of COVID-19. It is good at keeping research optional and definition open when we still don't know that much about long COVID and COVID-19 natural history and development. But it really goes beyond the COVID-19 pandemic. Long COVID is the voice of patients, and the voice of patients have often been marginalized in healthcare system, biomedical research, and medicine more in general. And this is especially the case for the voices of women, the disabled, and those from marginalized and minoritized community. And now that we have this new collaboration between medical professional, researcher, and patient, we really need to keep going in this direction to make medicine better and more attentive to patient. We really need to listen to patient voices and expertise in the year to come.
Horby. I'm the Executive Director of ISARIC. It gives me great pleasure to open this rather exciting programme that we have before us. This is a joint initiative between ISARIC and the GloPID-R Executive, but it's really been co-developed with patients. And I hope you all managed to watch the video. We just saw a very moving video about the impacts of COVID. This year has been an extraordinary and rather dreadful year. We've all seen some spectacular progress in diagnostics, understanding the virus, treatments, and more recently, very promising vaccines. But there are still huge gaps in our understanding of this brand new disease, and there's still a long way to go. It's a long road ahead of us. We're seeing light at the end of the tunnel, but this disease will be with us for many years, and there is still a lot of work to do. One of those big gaps, obviously, is long COVID or long haulers or whatever we want to call it. It's a real emerging serious problem. And this event really is an exciting event because it's been co-developed between clinical researchers represented by ISARIC, by research funders represented by GloPID-R, and by the community of patients affected by the longer term effects of COVID. And really what we're hoping to do is to really understand both the science behind long COVID, but also the personal impact of COVID. And from that, identify where the important gaps are and to co-develop solutions to those gaps, solutions that are actually important to people, solutions to problems that really matter, but also make sure we do that in a scientifically robust way so we can have confidence in our understanding of long COVID and how we're managing it. So with that, I'd like to welcome everyone, our co-chairs, our presenters, the audience, and our VRP guest, Dr. Tedros from WHO. And I'll hand over to my co-chair, Dr. Charu, to give the next part of this session.
So thank you, Peter, and welcome everybody. Good morning, good afternoon, good evening. It gives me great pleasure on behalf of GloPID-R to welcome all of you to this very important 2 days of discussions. As many of you would know, GloPID-R is a global research collaboration for infectious disease preparedness, which is an international network of research funding organizations that have come together to facilitate, accelerate, and deepen the collaboration among research funders on emerging diseases. And we are delighted for this collaboration with ISARIC to put together a forum which expresses patients' concerns and their priorities for research and where this needs to go. We know that this will be an important issue coming up as we hope that vaccines will help in decreasing case numbers. So we look forward to these discussions, and as funders, we are very keen to hear what the research gaps are and what patient priorities are. So with that, I would like to welcome Dr. Tedros. I think he needs no introduction. He is the WHO Director General, and we are very fortunate and privileged to have Dr. Tedros in person, given his extremely busy schedule that he has decided to give some personal remarks on this. And I'd like to start out by thanking him for his leadership during this last year and for constantly advocating for science, evidence, and patient and community voices. So Dr. Tedros, welcome to this, and we look forward to your remarks. Thank you.
Yeah, thank you. Thank you very much. First of all, I'd like to appreciate the welcoming from both of you, Professor Peter Horby and Professor Charu Kaushic, ISARIC and GloPID-R. Thank you so much for organizing this very, very important event. And good morning, good afternoon, and good evening to everybody. And thank you for inviting me to say a few words today. Although we learn more about COVID-19 every day, there is still so much we don't know. Over the past few months, evidence has mounted about the serious long-term effects of infection with COVID-19, from persistent fatigue, cough, and shortness of breath to inflammation and injury of organs, including the lungs and heart, and even neurological and psychological effects. The symptoms reported are serious and diverse, and I have listened to many, many stories. These complications have been reported among hospitalized and non-hospitalized patients, and among men and women of all ages. It's still difficult to know what proportion of those infected with COVID-19 suffer from what has become known as long COVID. Recently, I have had the opportunity of speaking with some of you and hearing your stories. Your request was for recognition, rehabilitation, and research. WHO is committed to supporting you in each of these areas. First, on recognition. We're raising awareness about long COVID with our member states and have spoken about it several times at our press conferences, and we will continue to do so. We're also working with patient advocacy groups like Long COVID SOS. A major priority is gathering patient perspectives in order to inform the development of our clinical practice guidelines from a patient perspective. Second, on research. Since the beginning of the pandemic, WHO has convened clinical researchers weekly to share experience and review the constantly evolving evidence. Alongside ISARIC and many other global partners, this group has led the development of the WHO clinical platform, which will soon launch the fourth case record form, a tool for clinicians and researchers to collect standardized data in order to facilitate a better understanding of this new syndrome. Of course, WHO is not a funding agency, but in selected research areas, we would be happy to put our resources to and to contribute to funding. And third, on rehabilitation. We're working with governments, patients, and clinicians to establish best standards of care to accelerate recovery and ensure patients get the care they need, including rehabilitation. WHO is now working to update its clinical guidance on COVID-19, which will include a new chapter that will describe the best practices clinicians can follow when caring for patients after their acute phase. The more we know about COVID-19 and its consequences, both in the short and long term, the more urgent it is that we all do everything we can to end the pandemic, prevent suffering, and save lives. I welcome this conference, and we look forward to working with you all in the months ahead to ensure that all long COVID patients get the recognition, research, and rehabilitation they deserve. Thank you so much from myself and my colleagues here. We have Maria Bankerkov and also Janet Diaz, who are working very hard on this area. And I'm glad that you're partnering with both of them. And I know our partnership will succeed. Thank you so much.
Thank you very much, Dr. Tedros. Very thoughtful remarks, and we are very glad to have WHO and Janet and others who are participating in this forum for the next couple of days. So with that, I would like to welcome Dr. Margaret O'Hara. Dr. O'Hara is the co-founder of the Long COVID Support Group and a person living with long COVID. She has been involved in patient advocacy in women's health and doing patient-led research for over 10 years. After contracting COVID in spring 2020, she connected with other people with long COVID to campaign for recognition, rehabilitation, and research. She leads the medical and research pillar of long COVID support. So Margaret, I'll hand it over to you.
Thank you very much, Charu. My fitness tracker tells a story. I got symptoms of COVID on the 31st of March, and I was very fit and active. I had no underlying conditions, so I thought, well, I'll be back at work next week, maybe the week after. But April was a complete write-off. And into May and June, things got better a bit, but nothing like normal. And then in July, I crashed again. The symptoms that had gone came back. They were even worse than they had been in the first place. So I dragged myself back out of that. September came and I thought, oh, well, that took a while, but finally, I'm finally over it. And then October, crash again. Symptoms back again, breathless, fatigue, for no reason. So now we're in December and I'm feeling okay again. Have I recovered? I've got absolutely no idea. And that is why we call it the Corona Coaster. Back in May, I found this group, the Long COVID support group, and I was so relieved to find that it wasn't just me that couldn't recover in 2 weeks. And it was really great to speak to other people. This was back in the days when we were measuring our symptoms, our illnesses in days, which seems really naive and innocent now looking back on it, because you could put a 2 in front of those numbers now. We're into month 8, 9, 10 and still have symptoms. And the array of symptoms, you can see some of them written here. Everything, every part of the body. I don't think I've seen a part of the body that's not been mentioned. I don't know, maybe eyelashes. I don't know, maybe eyelashes haven't been mentioned, but I mean everything else, from hair loss to COVID toes and everything in between. When I joined the group, there were about 500 or 600 people, and I offered to help. Claire Hasty set up this group, and she was pleased to have help because the group was growing. That group now has 31,000 members from all over the world. And we have a team of 20 people on 3 continents looking after it. But we're by no means the only group. There are hundreds of groups across the world. That last I checked, I could find groups in 23 countries, but that's probably not exhaustive. And one of the things we noticed, even months into the pandemic, the messaging was still very much, if you get COVID, if you've got underlying conditions or you're older, then you might have a really bad time. It might be severe. You might need to go to hospital. But otherwise, you'll be fine. It'll be mild and you'll be at home and you'll get over it in 2 weeks. So we were there thinking, well, first of all, that wasn't mild. We weren't admitted to hospital, but some of us were turning up at hospital and not being admitted because we weren't bad enough. A lot of us have the experience of really actually not knowing whether we would wake up in the morning, really worrying about that. And we felt like we were just left out and we have to let people know we exist or we're not going to get healthcare, we're not going to get the research we need. So we formed campaign groups and we talked to politicians, healthcare providers, doctors, media, anyone we could, to make films like the ones I show in the slide here from UK, France, Spain, and no doubt there are others in other countries. And we were doing this while we were ill. We were making these things literally from our sick beds. I haven't seen so many people's bedrooms on Zoom in my life. But not just campaigning, we were doing research. Very early on, the Body Politic group on Slack started doing research, and they've now developed the patient-led research group. Back in May, they were the first to publish on non-hospitalized patients with long COVID to try to just examine and describe what is this thing. And so far, they've come up with a list of more than 150 symptoms. I also highlight Jez Medinger, who's a fellow long hauler, and he's a filmmaker. And this is a lesson in how to engage people who are not used to being engaged with research. Jez dives into the hive mind of the online groups to focus on particular questions that we have. And he surveys the group for their views and opinions. He marries that up with existing research and produces these short films that are focusing on one particular aspect of the illness. And those questions are many and varied, like the symptoms. So there are hundreds of questions. I couldn't list them, but I think they come under 3 broad categories. First of all, why me? Why did I get this long COVID? Why did my colleague, my friend, my sister get COVID and recover quickly? What is it about my genes, my biology, my situation? And is that a lesson for other people? What is causing my illness? I have these symptoms, they come, they go. I've got no idea what's going on. Is the virus still there? Is it inflammation? Are my organs damaged? What investigations do I need to get to the bottom of it? And how do I recover? I need my life back. I need to go back to work. I need to look after my kids. I need to look after myself. Should I take vitamins? Should I not? Should I exercise? Should I rest? Are there any medications that I can take? Is there a rehab program? And can somebody help me? Because we're all doing this on a DIY basis. So we need research, we need professional researchers, because we know that there is a limit to how far you can go with online self-reported surveys. We know that that's biased sampling and retrospective. We need good quality, unbiased prospective work to describe what this is. And we need lab biologists to try and understand the underpinnings of it, to tell us what's going on. But we don't want the research community, the professional research community, to ride in like the cavalry and say, okay, stand back, we'll take it from here. We don't want to stand back. We have the best part of a year, we have a bedrock of the best part of a year of knowledge of this condition, living and breathing it and sharing it with each other. So we have a lot to share here, and we want to work with you. The NIHR is the largest healthcare funder in the United Kingdom, and it has a very well developed programme of patient involvement in the development, design and management of research. And it says that healthcare research should be done with or by patients, not to, about or for them. So that's what we want. We want you to come with us and join with us to create the research that we need to answer the questions that we need to be answered. Because in healthcare research, as in healthcare itself, there should be nothing about us without us. And I'd like to pay tribute to all my fellow COVID long haulers and all the work we've been doing and all the researchers we've been speaking to, and to ISARIC and GloPID-R for this excellent conference. They have been fantastic to work with. And thank you very much to Dr. Tedros for coming and speaking to us and addressing us live in person. And I'd like to hand back to Dr. Charu now.
Thank you so much, Margaret, and really, really important issues that you're bringing up. That's exactly why we're here. From ISARIC and GloPID-R, we want to take a holistic view of what people who are living with long COVID are going through. And we want to hear patient voices. We want to include them in research. I think more and more funders are moving towards that we need to have research that addresses concerns of people who are living with the conditions, not just academic research. So thank you for starting that off. We will be hearing from more global patients' voices. So we've put a lot of emphasis in the program to make sure that we hear global voices. So the next session will actually start off with listening to global voices of people who are living with long COVID. But I do ask everybody to stay online for just about a minute while we switch speakers. And I'd like to thank Dr. Tedros, Margaret, and Peter for being here for this opening session. Dr. Tedros, again, thank you so much for taking time from your very busy schedule. And I hope you will be able to stay and listen to as much as we can. We're going to start with patient voices. So welcome back, everyone. So we will start off our first session listening to global patient voices. We will hear in this session from 3 people who are living with long COVID in different parts of the world. We will learn the impact this condition has had on their lives, what their main symptoms are, what questions they would like to have answered, and to share research they are leading on. So we will start off with Dr. Nisreen Alwan from the University of Southampton. Dr. Nisreen Alwan is the Associate Professor in Public Health, University of Southampton, UK, and a person living with long COVID. She has particular interest in the wider social, economic, environmental, and cultural determinants of health in women and children. During the pandemic, Nisreen has focused on public health response, the inequality angle of the pandemic, the emergence of long COVID, how to define it and measure it, and why it is so important. So welcome, Nisreen, and please lead us off.
Thank you very much, Charu. So March 20th, 2020 is a date I'll remember very clearly. It's the date when my first symptoms of COVID-19 started. They were not bad enough to seek medical help or go to the hospital. We're told to stay at home at the time. I'm based in the UK. There were no tests available to confirm the infection for community cases. 2 to 3 weeks later, I'm still symptomatic. I'm worried now. Not sure what's happening. We were told this, from so-called mild cases, this should be over in under 2 weeks. But others are reporting a similar story on social media. So I'm reassured I'm not the only one. April and May, I had good periods and bad periods. For a couple of weeks, I almost felt completely almost recovered completely, but not quite there yet. I worked hard throughout, given my position in public health and the pandemic situation, so I didn't get enough rest, but June was pretty bad. In July, I wrote a British Medical Journal blog, and I started it by saying, it's the morning after I went out for a 20-minute slow walk yesterday with my little girl who was desperate to go out and see the flowers. My exercise capacity is still terrible, and I knew that by doing that, I would pay the price the day after. Indeed, I woke up with the familiar chest heaviness and utter exhaustion, which gets worse by sitting at my desk to work. I have no proof of my infection other than the accounts of thousands of other people who are describing a similar experience of prolonged, fluctuating and debilitating symptoms months after the start of their infection. This piece was called, "What exactly is mild COVID-19?" I also said, we need to measure this. We can't fight what we don't measure, and we're not measuring morbidity from COVID-19. In August, I wrote a piece in Nature saying, entitled, "A negative COVID-19 test does not mean recovery." I also said there, as long as long COVID is labeled as anecdotal, it will not be taken seriously and public communication will neglect it. We need to quantify it properly and accurately. We must measure recovery in those not presenting with severe disease at the outset. So in September, I told my story live in the first medical journal webinar on long COVID. It was a British Medical Journal webinar as well. I again said we need to measure recovery because it looks like long COVID is very challenging to measure as a condition. But even defining recovery is really difficult. We recently did an online survey of over 2,500 people with long COVID, and over 70% said their symptoms were like mine and like Margaret's. They're fluctuating, they come and go. How long do we wait until we declare someone's completely recovered? So that's difficult. We must find a way to have systematic and inclusive clinical case definitions, which are not entirely dependent on each healthcare provider's kind of professional variation and judgment. It needs to be a systematic way. People presenting with long COVID have the dilemma of recognition, like Dr. Tedros pointed out, if they weren't formally diagnosed at the start and they didn't have a test particularly. Because this is not just about seeking medical care. This is about people trying to get some time to rest and recover, so access to sick pay and benefits. And we know that testing is not accurate, whether it's testing for the virus or even for the antibodies, where there is evidence of waning of antibodies after months. I've got a collection of questions. There are so many, but in addition to how is long COVID defined, I want to just quickly run through them very quickly. Obviously, we want to know how common is long COVID. We want to know who is more likely to get it, who's susceptible. We want to know who's more likely to recover from it once they get it. We want to understand why people get it, and we want to know how it can be treated. Is it one medical condition, or is it several distinct ones? Can the pattern of symptoms predict progression and response to treatment? What does it mean in terms of long-term disability and mortality? What can be done in the acute phase of COVID-19 to prevent progression to long COVID? What's the burden? What's the burden it exerts on economy, on healthcare and social care systems? And how will disadvantaged and marginalized groups affected by long COVID be protected in terms of care, prevention, and employment rights? Can people living with long COVID get reinfected? Should they be shielding? Should they receive the COVID-19 vaccine? Indeed, should they be in the priority list for the vaccine? And what does long COVID look like in children? So it's not a black and white picture. We know now there is this huge gray area of long COVID in the middle. And one of the main challenges of the next phase of this global pandemic, if not the main challenge, is to quantify long COVID, prepare our systems for it, help those affected by it, and prevent more people progressing into it. It's an enormous task, but we must do it. Thank you very much.
Thank you so much, Nisreen. It's really, really important questions that you articulated, and I hope that we will hear more of these and we're able to have a list of summary questions at the end of this, that can be addressed systematically. But so important to hear from from people with lived experience on what their priorities are. So thank you for that great start to this session. And next we have Mr. Lawazi Malaba. Lawazi is a person living with long COVID. He is from South Africa support group. And he has a degree in social sciences, certificates in business management and facilitation, extensive experience in corporate South Africa and government entities as a management and leadership consultant. His areas of specialty include, among others, leadership training, strategic management planning, and change management with a focus on community upliftment programs through health, information technology, skills development, job creation, and education. Welcome, Lawazi, and we look forward to hearing from you.
Thank you very much, Charu. It was the end of April. We were in lockdown in South Africa, level 5. We had mobilized food parcels for my community. I am in rural Durban of South Africa. It was a difficult time, and it was a Sunday that I noticed that I was not feeling okay. I was breathless, I was sweating. I woke up with terrible night sweat. I thought I am definitely with COVID. We were told to stay away from hospitals and only go there if we have comorbidities, and they were explained. I have just turned 43, so I thought I'm pretty okay. It is December, I still feel the same way. Yesterday, I flew out in the morning to a mapping meeting with the AIDS Foundation of South Africa. Flew out at 8 in the morning and flew back at 1600 in the afternoon. I am having a terrible day today. I'm breathless, I feel hot. I'm experiencing again extreme fatigue, and it seems to be related to my travel. What I would like to know is, will I be reinfected? Because we are seeing incidences in South Africa climbing, and we are told we are possibly in the second wave of COVID-19. What we fear in our group, I started a Pan-Africa support group for COVID survivors, is the definition of symptoms. What are they? how do we identify and how do we treat? The understanding of where do we get support. For us, I suffer from depression. And so it has triggered my depression because you feel isolated, you feel by yourself. The virtual world is not a world we are familiar with as Africans. We are a social people. And so this has put a stress and a strain on how we socialize normally. And so it's an interesting time and very scary. Most of the people that are in the group with me have asked that we again speak to what Dr. Tedros spoke to: recognition, rehabilitation, and research, because we do need to make sure that we do not have out-of-pocket costs as we seek primary health care. South Africa has got the highest burden of HIV. We need to understand what is the impact of COVID-19 on HIV patients and TB patients. We need to understand also to what degree do we need to mobilize domestic resources for our response as a country to COVID-19, whilst making sure we do not lose the gains that we've made on HIV, TB, and STIs. It is also important to make sure that we undo the damage that has been done through the work that has been, I think, shown to the rest of the world by the leader of the United States, because it has been, for the most part, confusing. Most of our people do not believe there is COVID-19 because there has been a denialism around COVID-19. There was parties this past weekend, and that we were told now by the Ministry of Health that those parties and large gatherings were super spreaders, and that is why we're seeing a spike. It is important that we also speak of and speak to patients whilst we are doing research, so that we've got lived stories of those who have experienced COVID-19. I repeat everything that has been said before me, and I thank you for the platform.
Thank you very much, Lawazi. And it's, it's really important to hear these different perspectives of how people living with the same experience, put into a different social context. It can be so isolating and, really important points that you brought up around the way the societies and the social structures function differently in South Africa versus, some of the countries in the Northern Hemisphere. So those are really important points. And I really appreciate you bringing up the issues around HIV and TB in South Africa. I'm an HIV researcher myself, have been for 20 years. And many of us, even as researchers, worry about the, how COVID is putting us behind in making gains for HIV and TB progression. So thank you for that very thoughtful, concerns and points. And hopefully we will have more discussions over this over the next 2 days. I would like to introduce our last speaker in this session, Ms. Basha Mewar. Basha is a person living with long COVID from India. And she has studied art history, psychology, and French. And she has been suffering from long COVID since March 2020. Basha, please go ahead and talk to us about your experiences.
Hello, everyone. So thank you so much for giving me this opportunity to talk about my long COVID experience. So I'm just going to talk about my, it was a harrowing experience, of course, as it is for most of us. And it started with atypical symptoms. So I was suffering from fatigue and weakness, and I actually went to the doctors, and nobody suspected COVID. And by that time, my country was in lockdown as everyone else. And it was difficult to get doctors' guidance. So me with my 72-year-old mother, we walked all the way half an hour to the government hospital to try and get a COVID test, because I knew in my bones somehow that this was not just a normal illness. I was suffering from COVID. And of course, I was not given the test because at that time I did not fit into the criteria of cold, cough, or fever. I never had a fever in the last 9 months. And then went on, of course, to develop vomiting, diarrhea. I now believe, I think I had a hiatal hernia as well because I could not eat anything for 2 months. The stomach was inflamed. I had breathlessness. So there was almost like an elephant sitting on my chest. And all this happening while we were in lockdown, while my neighbors, because of the stigma that we had in India, people would, if they found out that there was COVID or somebody was trying to get a COVID test, they would not let, milkmen to come and deliver milk or food. So me and my mother have spent 3 months in isolation. I think I started to suffer from depression, panic attacks because of all of that. And yes, I was trying to get in touch with doctors all throughout this period of complete isolation. So nobody could visit me. I could only talk to people over the phone. And if I didn't have the phone, I don't know what I would have done. Honestly, the internet and the phone. So, and the first article was The Atlantic by Ed Yong that I found out about long COVID in May. And that is when I came in touch with the long COVID support group on Body Politics Slack, as well as on Facebook. And that's been really a savior for me. I just want to say that just like Margaret, just like everyone expressed, this is really a corona coaster. It comes and goes. I don't know the next morning what I'm going to be facing. So today I would have extreme chest pressure, dizziness, fatigue. Tomorrow I might be having gastrointestinal issues. So for me to actually get tests that really showed what is happening at a particular moment of time was the most difficult. Secondly, nobody believed in long COVID at all, or COVID beyond, say, 3 weeks or a month. So there is a lot of problem in terms of recognition in the medical community. Till this day, I have not met any doctor, specialist, a general physician who knows about long COVID. And it's been 9 months that we've been talking about it. So I know there is a bubble online where I can talk about it, but when I come to my reality, I'm in an isolated sort of island space. So for me, the term long COVID is quite important, and I had mentioned that earlier as well. Just as a formal diagnosis, even though we are learning about it on a daily basis, if the general physicians to a core grassroots level know about this term or are updated to the knowledge that we have so far, that recognition itself, the first step itself, feels like it hasn't happened yet. And because of that lack of recognition, a lot of long COVID patients are feeling gaslit, they are feeling depressed because I have to talk to my doctor, even though I know what I'm going through. I have to talk to my doctor in individual symptoms. So I go and ask them about my gastrointestinal issue. I will go and ask pulmonary, for pulmonary issues. So it's not holistic, and therefore, if I mention long COVID, I am told that it's probably in my head. It's something that I'm going through psychologically, or it's really hard. It's not easy because you have this wonderful support group on your phone, but when you come out of your phone, you feel like you're lost. You're in an island. So recognition before treatment, actually, because if you don't know what is happening, if the doctors don't know what's happening to you, how are they going to treat you? So I feel that that's the first step before we move into treatment. And of course, I've spent my life savings on treatment, on medicine. I'm going for Ayurvedic treatment, homeopathic treatments. I'm going for allopathy. I'm doing everything, but I don't know if it's right for me or for anybody else. And I don't know the long-term impact of the number of medicines that I've taken, just guessing and trying to help myself. So I hope that it's not a too honest or too brutal way of saying it, but it is very, very difficult for all of us. And the opportunity that I get here to speak about it, I am really grateful and I appreciate it. So thank you so much.
Thank you so much, Pasha. It's really, really important for us to start this meeting hearing from patient voices, because it's not easy for people to share these experiences as you've articulated so well. It's very isolating, it's stigmatizing, but yet it's so important for us to hear what are your priorities. So you articulated in a really nice way that, you would think that suffering from these symptoms, the first thing on your mind would be, how can I feel better? But it's really interesting to hear you say that, you'd like to be recognized first for what you're going through. And I think we've heard that from Nisreen and Lawazi as well. I know we're running tight on time, but maybe I can get a quick comment from Nisreen and Lawazi, to hear sort of their priorities in terms of treatment, recognition, research. Where do you think the first focus needs to be? Nisreen, can I start with you?
This is a very different question, Charu. I've listed just a sample of questions, but where do we start? I mean, I focus mainly on, I think, given my other hat on in kind of epidemiology, public health, about measurements. And I think everything, the way we're handling the pandemic now starts with how religiously we've measured it. But that was mainly in mortality and kind of number of cases. And I think we need to take a very similar, serious approach to measuring long COVID, even though everybody recognizes more challenging. But I think once we start quantifying things and measure them correctly, then that kind of gives us some clues in what to do next in terms of, having maybe different types of different group of people requiring different treatment, and maybe different management. I think now there is this umbrella term called long COVID, and I hope this today and tomorrow and this conference will help us refine this a bit more, because there's something wrong. It's long COVID is wrong, but I think we need more refinement, and the refinement has to be with trying to measure things accurately.
Yeah, thank you for that thought. And I'm being told that Lawazi just dropped out of the meeting. So clearly, like he said, he's not having a good day. And it's just tells you how hard it is to go through, from day to day. So important discussions. And thank you both and Lawazi very much for sharing these experiences. Hopefully we will continue to work on this over the next 2 days and come out with very specific priorities and be able to articulate clearly for patients, for researchers, for other stakeholders, including funders, where our focus needs to be. So thank you very much, and we're right on time. So we will, I ask everybody to stay online while we switch to the next session. And I would like to welcome my colleague and co-chair from GloPID-R, Dr. Charles Wesonge, who will be chairing the next session. So thanks, everyone.
So we thank Charu for the previous session and for the introduction to this session. In this session, we will provide a summary of the science of long COVID. The first presentation is a rapid living systematic review of the characteristics of long COVID by Dr. Haritine Stavropoulou and Dr. Louis Siegfried. Haritine is from City University in the UK and has a background in health economics and policy, and has been doing research on the role that patients and the public play in health and healthcare. Her co-presenter is Dr. Louis Siegfried from the University of Oxford, also in the UK. Over to you.
Thank you. Thank you very much, Charles, and thank you very much for giving us the opportunity to present our work in this brilliant forum. So what I will be presenting is the work that we have been doing with Louise and other clinicians, methodologists, health services researchers, and of course the long COVID support group in an attempt to systematically summarize and synthesize the evidence that we know so far about long-term COVID-19. So we did this work in order to understand the landscape, as I said, and I'll try to move my slides. There we go. In a way that it will bring all the evidence together in one space. The beauty of of the living systematic review is that we will be frequently and regularly updating the review to come up with the new evidence that we know that is being undergoing and is published as we speak. So what we did was to look at studies with people who had confirmed or suspected COVID-19 that were hospitalized or treated or managed in the community, and they were published in peer-reviewed journals and with more than 100 participants. So 28 studies met the criteria we had set, and they came from different parts of the world, 13 countries so far, and you can see that they are predominantly from places that they had high prevalence of COVID-19. They focused on participants that they were adults so far. They had, and the longest they had followed up participants for were 3.7 months post the hospital discharge. They used different types of study designs, but none of which could allow us to establish causal effects. So this slide here will hopefully give you will make it very clear that long COVID is indeed it has a breadth and of symptoms, and the depth of the symptoms also can be highlighted from these two graphs. But I think very importantly, as Dr. Tedros mentioned earlier, we did find evidence that the long COVID affects both those who were hospitalized during the acute phase, and you can see that on the right-hand side, but also those who were they were managed in the community on the left-hand side. And very importantly, there are not major differences between the two groups as we speak. Of course, these are the reported symptoms, so we are aware that there are other symptoms that may not have been reported in the studies that we have reviewed so far. Now, when we try to answer the question of how frequently you will see these symptoms lasting for, we couldn't really answer this question because we identified high variability in the symptoms prevalence. So when someone asks how often would you expect to see certain symptoms, let's say psychological symptoms lasting post the acute phase, it's quite hard to say because the variability among the different studies was quite high, which is why we could not perform a meta-analysis in our studies. But to sum up, we have very strong evidence that indeed the long COVID can be seen in both hospitalized and non-hospitalized patients, but the evidence so far is quite limited, and the data that we could find were quite heterogeneous in nature. So we identify in our study, in our review, a number of research gaps, which I'm sure that they will be discussed throughout this today and tomorrow in this forum. And to start with, we need a clearer case definition of what long COVID is. We also need high quality case control studies, so studies that will allow us to establish also causal links between COVID and the symptoms that will be observed later on. And of course, follow-up studies, longer follow-up studies on populations and settings that we know that have been understudied, such as children and young people, those who were managed in the community, and of course low middle income countries, because as we saw earlier, there's not much evidence there. Over to Louise now for
Thank you.
presentation of the work.
Thank you. So as we can see, there was the evidence base that's been published on long COVID is still limited, and there was high heterogeneity in the study designs. So in parallel to the Living Systematic Review, ISARIC, and also in light of the emerging evidence on COVID, we established a global working group with a range of specialists with 46 members from 17 countries now to develop a study into long COVID. So we developed a protocol and standardized forms to follow up people over time. And it's linked with the ISARIC WHO COVID clinical characterization protocol. So the follow-up data that we collected can also be linked with the clinical data already documented in the study to evaluate risk factors for long-term complications and sequelae. So these forms have been developed to enable wide dissemination in different resource settings. So the follow-up forms can be administered to patients post-hospital discharge via telephone, post, or as an online link, or for follow-up in clinic visits. So the follow-up forms will document data on physical health and psychosocial complications and impact on occupation and other factors. And they are currently set up in, so we've set up the global studies, a global collaboration, and we currently have data on about 500 people documented from 5 countries. And the studies is being set up in sites in Europe, South America, and Southeast Asia at the moment, looking at following up a high number of people to establish the risk of different types of long-term sequelae and risk factors for prolonged sequelae and characterizing the long-term outcomes in different populations globally. So we have forms to follow up adults and children. And they are open access, and they are free for any sites to adopt and adapt for their setting for independent studies or to join this global collaborative effort to forward the evidence base into long COVID. So if anyone's interested, please visit our website at isaric.org or contact us after the meeting. Thank you.
Thank you so much, Aritine and Luis. The next presentation is on active long COVID research by Dr. Alice Norton. Dr. Norton is the head of COVID Circle and has substantial experience of global health research, policy, and funding. Over to you, Dr. Norton.
Thank you very much, Charles. Thank you for that introduction. Indeed, I'm here today to tell you about some work that we've been undertaking collaboratively between the UK Collaborative for Development Research and the GloPID-R group of funders. At the outset of this pandemic, the World Health Organization, in collaboration with GloPID-R, organized a meeting in February, which resulted in a global research roadmap for the research needs to address COVID-19. What we then decided was necessary was a tracker to track the research investments being made around the globe and see how these then aligned to that WHO research roadmap. So this slide here shows an infographic of what that data looks like currently. So it's been a huge effort by multiple partners and by the funders openly sharing this data as rapidly as they can into the tracker for us to then categorize it against these WHO categories. We currently have over 5,000 research projects captured in the tracker, all related to research on COVID-19 across the full spectrum of research that we can capture. And you can see on this infographic that that's quite varied at this highest level. And we capture data both on the numbers of projects and the amount of funding that's gone into them. This tracker currently contains data from 71 different funders, with the research taking place across 134 countries. So it is by no means exhaustive. However, it does provide a pretty robust data set on what's going on globally. And funders have been using this to improve their coordination, and researchers have also been using this to ensure that gaps are filled and that collaboration happens where it's needed. So of course, we've looked to this tracker to then see what evidence there is in it on research being funded to address long COVID. So out of those over 5,000 research projects in the tracker, only 45 looking at the content of what's in those research projects appear to be addressing research related to long COVID. So what does that look like? About 69% of them are looking at the spectrum and the causes of long COVID symptoms. The remainder are starting to look at risk factors, management and treatment. In terms of the approach, 84% of the projects look at populations, and they are all focused on adults. There isn't a single project within the tracker currently with a focus on children. And these 11 studies are using cohorts, so longitudinal population studies for their investigation. There's a mixture there of cohorts on individuals who have tested positive for COVID and some cohorts of the general population, which might pick up asymptomatic or non-diagnosed cases. The remainder of projects in the tracker are around digital innovations for management of long COVID, and there's just a couple on animal models for long COVID symptoms. What aspects of long COVID are they looking at? We've heard about the range of different symptoms there might be. Again, looking at what's being funded, there are projects focused on individual parts of the body and the effect of COVID on it and long COVID. And then there's some more descriptive, non-specific studies looking across the range of symptoms in the tracker. So where is this research taking place? Now you'll see there's some differences between this map and the map presented in the prior presentation. So here, what we are looking at obviously is funding in rather than publications coming out. And we're aware of some limitations in terms of capturing funding data in certain places where there's been a lot of research going on, such as China. But what we show here is the picture of what we've managed to capture, showing a lot of the limited active research taking place in the UK, North America, and in Canada, and a few research projects being funded more broadly across lower or middle income countries. We also see a couple of collaborative projects collaborating globally, but the majority are in individual study locations. So what's coming next? What this tracker really enables us to look at is a pipeline of research that's coming through that may then come to fruition and lead to results to fill in some of those knowledge gaps. What obviously we're interested in also is what active funding research calls are. And from the UK Collaborative on Development Research, we're obviously very aware that one of our members, UKRI, currently has a large funding research call out in this area. And we're aware of other funders who are obviously looking very closely at this area and listening today to hear what the research priorities might be. So I'd like to thank my colleagues at the tracker, in particular, Emilia Antonio and Adrian Buscher, and the funders of UKCDR and GloPID-R. Thank you.
Thank you, Dr. Norton. I thank all the participants in this first set of sessions and the colleagues who have spoken at the session so far, starting with Dr. Tedros and ending now with Dr. Norton. I believe that at the end of the Global Voices and the evidence presentation, we now have a baseline understanding of the definition of long COVID. This may be refined as the meeting progresses. There is now a 5-minute comfort or stand-up break. Thank you so much.
Everyone, I'm Jen. I first acquired COVID-19 symptoms on the 20th of March at the age of 38. I was working full-time in a senior management level role and fairly fit.
Hi everyone, my name is Bharsha and I'm from Gujarat, India, and I've been suffering from long COVID since March.
I'm now 8.5 months into my journey of long COVID, currently lapsing and in day 4. My symptoms include diagnosed post-COVID tachycardia and acute fatigue. I also have chest tightness and breathlessness from time to time, low mood and anxiety, muscle aches and pains, especially in the evening, memory loss, and insomnia.
My symptoms started with extreme fatigue. All the energy was kind of taken out, and I had gastrointestinal, so GI issues from the beginning, gastrointestinal issues. So I had a cold, feeling like I was having a cold 10 days before I started to have GI issues. But that cold was so minor, it didn't feel like it was COVID. And at that time, we didn't know all of the symptoms clearly. And so that sniffle led to GI issues that have gone on for the last 8 months. I've also had extreme fatigue, a tight pressure around my chest, so almost like an elephant sitting on your chest, breathlessness after that. I've had a congestion. I've had heart palpitations, so tachycardia. I've had urinary tract infections. I've had 3 to 4 up in the last 7-8 months. I've also had extreme brain fog, depression, anxiety. I've had panic attacks. I've had a lump around my ribs, so pain in my ribs, extreme pressure around my ribs, so I can't breathe really well.
I'd really like to see research in 3 areas. 1, really good profiling and understanding individuals who seem to be predisposed to long COVID or who acquire COVID-19 and can't recover as quickly as others in a matter of weeks, and why that is, in order to try and protect individuals in the future who acquire the illness going through what we have. Secondly, really good research into what interventions should be in place far earlier in the recovery journey for long COVID patients. This can be the holistic services, a package, services including physiotherapy support, psychosocial services, understanding what access to finance and financial support's available. Many of us have lost our jobs or are unable to work, and this has had a massive impact on self-esteem and recovery. And lastly, monitoring and evaluating our recovery as, I guess, the first generation of long COVID sufferers in the community who fell ill around March, April time, and we feel haven't really been looked at or monitored. It's going to be so important to try and take that opportunity up, to see how we progress, to cover our lapses, hopefully to reach progression to full recovery, and to keep monitoring us in the future for the sake of others. Hopefully they won't have to go through what we have.
We need post-COVID clinics. We need long COVID as a term. We need general physicians to understand what we are going through. We need employers to understand what we're going through. I have an employer who has kept me hired, but a lot of people have lost their jobs. There is so much to be done that I'm sure all patients would like to speak for a longer time if they could. Research and long COVID as commonly known as the common cold, I hope, because yes, a lot of us are suffering a lot. Thank you. Thank you.
So good morning, good afternoon, good evening to everybody. We're going to have the second session, What Do We Know About Long COVID from Country Experiences? I'm Roberto Bruzzone, the chair of ISARIC and also co-director of Hong Kong EU Pasteur Research Poll. And I will be co-chairing this session together with Janet Diaz, who is head of clinical care at WHO. We will learn from 5 speakers from across the world about what they're doing in their areas, in their countries, to understand better what are the long COVID experiences from patients and what studies they are trying to develop in order to get into a mechanistic understanding of long COVID. These presentations will be followed by questions and answers, so send your questions to the Q&A platform. We'll try to get to most of the questions. Of course, we apologize for not being able to get them all and try to get a good discussion at the end of this. We will start with Hong Kong and Professor Ivan Hung, who is the head of the Division of Infectious Diseases at the University of Hong Kong. Ivan, the floor is yours, please.
Thank you, Roberto. Very kind of you. So I'll be speaking from the Hong Kong perspective in combating COVID-19, the Hong Kong experience. The latest situation in Hong Kong, of course, is that we are currently at our so-called 4th wave in Hong Kong. So we have a so-called minor 1st and 2nd wave, which is mainly imported cases, and now we are in the just in the 4th wave, which majority of the cases are caused by the Nepalese clade in the 3rd and the 4th waves currently. If you compare that to New York, of course, we are similar in size and population. Nevertheless, we are much densely populated despite having a larger areas because most of our areas are in our so-called country park. Nevertheless, we are currently just having more than approaching 7,000 confirmed cases with 112 deaths with mortality 1.6%. ICU occupancy still less than 50%. And that, of course, that the in terms of the compared to New York, which they have more than 600,000 cases, 34,000 deaths, and of course that the mortality rate is 4.9% with ICU occupancy 100%. I think one of the reasons why we are doing relatively well is the experience that we gained from SARS 2003, when we were actually the first team to identify coronavirus as the cause of SARS 2003, where we published 2 papers, including that, of course, is the pathology result that we identify from the one of the relative of the index case. And of course, at that time, the phylogenetic tree from the SARS 2000 from the coronavirus is much simpler compared to now. And subsequently, we also published another article in Lancet stating the various phases similar to that of COVID-19 of so-called cytolytic immune phases and convalescent phases of the SARS 2003. And of course, the team was led by K.Y. Yun and Monique Pierres, which if you look at them, they haven't changed much apart from probably for the hairstyle. COVID-19 this time, of course, we had our first cases comes in from China, imported in January during the Chinese New Year. And of course, we from the HKU Shenzhen Hospital, we managed to identify and reported the first, one of the first man-to-man spread, a Wuhan family moving down to visiting their relative in Shenzhen, the mother-in-law in Shenzhen, and passing the virus to the mother-in-law and causing a family outbreak in Shenzhen during the Chinese New Year, which we reported that in the Lancet very, very early on after the Wuhan outbreak, and proving that, of course, this is a man-to-man spread. Subsequently, we also reported from the Diamond Princess quarantine, the returnees, that was quarantined in a central quarantine at Jinyun Estate. And again, we reported in Lancet ID that one symptomatic patient of the returnees are associated with 2 asymptomatic patients that have no symptoms at all, but the X-ray and also the NPS shown to be positive for the COVID-19. And we were also the first team to report the first phylogenetically different of a reinfection case that we initially identified of the first sample in March, and then subsequently the same patient acquired a different clade, signified of course by the D614G mutation or the spike protein in the second clade identified when he returned from Spain in August, which he remained completely asymptomatic and just identified to be carrying the virus by screening at the airport. And of course, that at that time, the initial antibody was negative, and that it was a totally different clade the second time with 24 amino acid differences compared to the first time. I think one of the reasons why in Hong Kong we are doing relatively well is, of course, from the experience that we gained from 2003. And very important, as reported here, is that we have a very intense infection control measures. And hence, compared to other countries, we're able to flatten out our number of cases compared to other countries as such by a universal face masking very early on from the pandemic with very good compliance from our community. Social distancing, including, of course, very tight border control and screening of all the visitors and also local citizens returning to Hong Kong, and easily accessible diagnostic testing by using the frozen saliva testing, and also very good contact tracing, home quarantine, centralized quarantine, and also hospitalization for confirmed in the negative pressure facilities. So these are very important that allow us to treat our patients very early on upon confirming their status and also breaking the chain of the transmission. One important thing, of course, is the diagnostic test we use in terms of using frozen saliva as the COVID-19 diagnostic test, as seen here by our team, published in Lancet ID, that of course the IgG subsequently rise on the day 7, but picking up of course the viral load very early on from day 1 of hospitalization. And this was supported by the subsequent study from Yale, published in New England Journal of Medicine, about with a very good sample of the saliva, it could be better in terms of sensitivity when compared to nasopharyngeal swab, and especially during the first 14 days of hospitalization or of confirmation, and that of course that will save many PPE and also the manpower from healthcare workers needing to do a swab for the patient, and of course it's non-invasive as well. One very important principle is the antiviral treatment that currently not shown in many of the large trials, including of WHO and also NIH, is the importance of the timing of the antiviral therapy, that it should be given at the early commencement of antiviral combination therapy of the first week from symptom onset. It's no point of giving antiviral in the second or the third week, especially when the patient already developed cytokine storm and the viral load is relatively low. So by having an early antiviral therapy, you are able to increase the spectrum of activity, increase the potency, and reduce resistant emergence. And by suppressing the viral load, you are able to prevent the cytopathic damage, the cytokine dysregulation that happens in the second week, and prevent bacterial co-infection and complications in the second or the third week, and also reduce the viral shedding. So the importance, of course, is the timing of giving the antiviral treatment in the first week. And this is well demonstrated in the triple combination treatment that we show in using the interferon beta-1b, Kaletra, and ribavirin. That was demonstrated by a very good selective index of the CC50 over EC50 by looking at the interferon beta-1b, which is probably the best selective index of all, with 1,600 compared to interferon beta-1a, remdesivir, and also leponavir. And we are able to recruit all these patients due to the early isolation and quarantine of patient. And most of them was treated within 4 days from symptom onset. And this actually showed that we're able to have a better clinical alleviation and also suppress the viral in various specimens and also the interleukin-6 level. And finishing, of course, there are research gaps that we are needing. Of course, is the lack of international collaboration. A robust multi-center trial with a similar medical standard for comparison. Important is to need the combination antiviral treatment trial with early presenters that should be given in the first week, especially from symptom onset. Treatment trial on immunomodulators in the subsequent week, of course, is very important. And we need virological data and cytokine, chemokine data in order to support these findings in various modalities of treatment. And thank you very much for your kind attention.
Thank you, Ivan, for this tour de force presentation of all the current protocols and clinical studies that you are carrying out at Queen Mary Hospital. The next speaker is Dr. Priscilla Rupali, who is professor and head of the Department of Infectious Diseases at the Christian Medical College in Vellore, India. The floor is yours, please.
Okay, so hello everyone, and thank you to the organizers for inviting me here. I was especially hesitant to speak today as I was talking to Gail over email, and I realized that India is probably far behind the other countries with regard to recognition and treatment of long COVID. So a couple of months ago, when I was talking to Dr. Paul Garner about various other having systematic reviews about guidelines, he subsequently mentioned to me that he would be interested in long COVID. And that's when we actually started looking at our data, and I'll be presenting some of that today. So if you look at what is available now in the Indian scenario, there's hardly any data actually available. And this is from the Ministry of Health in India. And there is a very short paragraph about how to manage post-COVID patients who come for follow-up. I subsequently went on to do kind of a search to see, do we have any support groups in India? And I'm embarrassed to say there was just one newspaper report talking about a doctor who started a support group after she lost her husband. So it was a bit of relief for me to actually come across Basha, who said that she did have some contact with people in India who had also suffered the same scenario. Just to give you a little bit of context, we're actually an unaided Christian minority institution. In fact, today happens to be our founder day. But we are actually a high volume hospital. So in a day, we see about 8,500 outpatients. At any given time, we're about 2,500 patients. So till about September or so, we were actually dealing with acute cases. And we had a huge peak in September. And only from October onwards did our caseload start coming down. So I must say long COVID really didn't figure in the scheme of things because we were in the midst of the COVID pandemic and dealing with treatment problems rather than really dealing with chronic or subacute problems. So just to give you a little bit of heads up of how our epidemic evolved in our institution. So this is just a slide which tells you about our percentage positivity. And to the left of the slide, you'll notice the green line, which is coming down. And only now have we touched below 10%. And before that, it was 50%, almost all the cases which presented to us. So only now have we started to actually start seeing patients coming to us with symptoms which we know probably are now related to a post-acute COVID or recovered COVID or long COVID, as we saw. We did see a few patients in March, and this is kind of our IP admissions, our inpatient admissions. So as you can see, we peaked around August, September, and that is what we actually saw. So this is just one unit. So I'm an infectious disease physician. Just under us, we've had about 500 odd patients just from July onwards. And as you can see here, in these patients, we've had a mortality of about 6%. And coming to the post-COVID sequelae or long COVID, as we call it, we've seen about 11 patients, of which actually 7 needed admission. And others actually, we saw them in the outpatient. So this is the 7 patients who got admitted. Among the 7 patients who got readmitted, about 4 of them actually required, in fact, even non-invasive ventilations. The other things that we had been documenting was cardiac manifestations and pulmonary manifestations. These are the few X-ray findings that we came across in our patients, quite a few of them with lung fibrosis, which is, I think, being described everywhere else in the world. This is just a typical story of one of our cases. So if you just concentrate on case 4, who came to us about 3 months later with symptoms and went on to require admission. The other thing we started doing when we were dealing with this, as you can see, we were far behind Hong Kong. We hadn't really faced such a situation before about an airborne outbreak. So we started monitoring our patients with various other peripheral arterial thrombosis, venous thrombosis, and also some neurological sequelae. I think my slides aren't moving. I wonder if there is an issue there. But that is what we started noticing. And so we had some few patients with peripheral arterial thrombosis, some limb ischemias, some aneurysms, dissections. Then we had a few other patients who presented to us with chronic venous insufficiency, pulmonary embolism, and these are a few patients who presented to us with neurological features, myelopathies, encephalopathies, chronic venous, cerebral venous thrombosis, etc. So that's about it. As you can see, we are pretty early on in our, we haven't yet systematically started documenting. So the research gaps are such pretty much the identification of long COVID in India itself is a huge problem. We are touching almost 10 million cases in India today. And so it is actually a big problem for us. And we're looking forward. We have actually been in touch with various hospitals around the country, and they're actually going to be collaborating with us in documenting long COVID. So that's all I really have to say, and I'll be happy to take any questions if there are.
Thank you, Priscilla. I think questions will be all at the end. We continue our exploration in Asia. After Hong Kong and India, we move to Japan. So the following presentation will come from Professor Shinichiro Morioka, who is from the Center for Disease Control and Prevention in Japan, and also his colleague, Professor Norio Omagari from the National Center for Global Health and Medicine. Please.
Thank you. Thank you. Thank you, Dr. Professor Bruzon. Yes. I appreciate Dr. Bruzon for inviting us to this forum. My name is Dr. Morioka. Okay. Today, I would like to share the experiences in Japan. I am going to talk about the epidemiology of prolonged and late onset symptoms of COVID-19, research gaps, and future directions. We conducted telephone-based survey study of COVID-19 patients discharged from our hospital between February and June. One-on-one structured individual telephone interviews were conducted from July to August. We investigated patients' backgrounds and treatment, as well as prolonged and late onset symptoms and their duration. Results: a total of 78 patients were potentially eligible for the interviews, and 63 patients completed the interviews. This is the demographic and clinical characteristics of the participants. The mean age was 48 years old. 33% of the participants were female. The mean body mass index was 23.7, and almost 90% of the participants were Japanese. 58.7% of the participants had no underlying medical conditions such as hypertension, dyslipidemia, and diabetes. 75% of the participants had pneumonia, and 27% were on oxygen therapy. 8% were mechanical ventilation. This is the proportion of patients who presented symptoms after admission. 120 days after symptom onset, around approximately 4 months after symptom onset, dyspnea, fatigue, and loss of smell were appreciated around 10% of the participants. This is most important. This is about late onset symptom. 14 patients, 24% reported alopecia. 4 were women and 9 were men. The mean time from symptom onset to the emergence of alopecia was 58.6 days, and the mean duration was 76.4 days. Limitations: recall bias. It was a single center study with a very small sample size of only 63. Some patients still had prolonged symptoms at the time of the interviews. Research gaps: prevalence, type, and severity of symptoms. In terms of type, we did not explore other post-viral fatigue syndrome, such as depression, memory loss, and lack of concentration. Next, how symptoms affect patients' lives. This is very important. Some patients were not able to return to work due to the symptoms. And the risk factors of prolonged symptoms were not identified in our study due to a small sample size. However, in previous articles, there are known risk factors. Those are age, female gender, and body mass index. Research gaps. 2, etiology and pathophysiology. There are 4 hypotheses on the CDC website. 1, organ damage from the acute infection phase. For example, impaired pulmonary function was appreciated among SARS survivors. 2, manifestations of a persistent hyperinflammatory state. For example, long-term host response was appreciated among patients with sepsis. 3, ongoing viral activity associated with a host viral reservoir. It was reported in patients with Ebola virus disease. The last one is inadequate antibody response. The treatment of long COVID is still unknown, as pointed out in previous sessions. This is the last slide. Future studies in my hospital. We are going to investigate prevalence, type, and severity of prolonged symptoms for longer periods with larger sample size. Also, we are going to identify risk factors of prolonged symptoms, and as well as the association between antibody titers and prolonged symptoms. Thank you so much, and I would like to turn it over to Dr. Bruzan. Thank you.
Thank you. I think that is there finished the presentation? Is Dr. Wagari presenting something, or this is a joint presentation?
Thank you. This is the joint presentation. Thank you so much.
Okay, thank you. Then I'll give the chair now to Janet Diaz, please. Janet, thank you for taking over. Thank you.
Thank you. So thank you, Roberto, and thank you, colleagues, for organizing this this excellent conference. It's my pleasure to be here on behalf of WHO. So next on the agenda, I'm privileged to introduce Professor Christopher Breitling. He is the coordinator for the European Union Consortium AirProm, MRC/ABPI COPD MAP Consortium, the MRC Molecular Pathology Node, EMBER, and respiratory lead for the IMI 3TR. His research focuses on improving the clinical management and understanding the immunopathogenesis of the airway diseases such as asthma, chronic cough, and COPD. And he's affiliated to the University of Leicester in the UK. So over to you, Christopher.
Many thanks for that kind introduction. So as you say, I'm Chris Breitling from Leicester in the United Kingdom. And what I'm going to present is really the UK approach to long COVID. So our peak in the first wave in the UK was in April. So discharges really started from March. So we're now looking at patients that are up to 9 months since discharge from hospital. And importantly, in the UK, the initial testing strategy was really focused on people who were admitted into hospital. So those with a certain diagnosis of COVID-19 initially were largely restricted to those people in hospital. And it's only in the last 5 or 6 months where there's been a much greater recognition and then testing strategy within the wider community. That's notwithstanding the reality that obviously lots of people in the community were getting COVID at the same time as people were being admitted. But my reason for saying that will become obvious on this next slide. So I just want to really give you the landscape within the UK. So I coordinate the FOSP COVID consortium. This is a national consortium. And our vision is to then establish a national platform to integrate research into clinical service to understand and improve the long-term outcomes of people who've been hospitalized and survived COVID-19. So this is across the whole of the UK. We have now over 50 hospitals involved. We're planning to recruit 10,000 individuals over the next year or so. We've already recruited our first 1,500. And we're then looking at some of those in tremendous detail where they're having repeated measurements, which include collections of bioresource, imaging, and patient-reported outcomes. So that's the background to FOSP, which I'll come on to a little bit more in the next slide. But I'm just showing you here how it sort of maps onto other activities within the UK. So we are all familiar with the ISARIC international platform, and FOSP COVID that includes patients that have been enrolled into ISARIC in the acute episode and are then following those patients up. So it can be seen in some ways as a UK sub-study of the ISARIC patients within the UK. We're also well linked into other national platforms such as immunology platforms, which will be looking at the serial antibodies, but also looking at immunotyping of cells in the long COVID patients. We also have a major focus on the effects and impact in neurological systems and also on psychology and psychiatry. And we're linked in then to what's called COVID CNS, another national platform. So these are all people who've been admitted into hospital. There will be set up at the beginning of 2021 similar community focused studies, and that's now at the moment being decided within the UK. There's also now policy. So in the middle of this slide is then the policy, which is then focused through the National Health Service, where we have a case definition, which is being agreed through the NICE guidelines. But we also have a series of pillars, which then include the underpinning research, the establishment of long COVID clinics, which are now being established across the country, a standardized rehabilitation approach, which is based on a web delivery of rehabilitation, so a website, but also then we'll be moving into face-to-face rehabilitation. And then overarching this, we have a long COVID task force, which is then looking at both research and care delivery. We also have a number of epidemiology studies that are ongoing, looking at long COVID, including a series of birth cohorts, and also other studies that have been established specifically to then look at COVID-19, such as Confidence and React. We're also linking into initiatives beyond the UK, So for example, in my role within the European Respiratory Society, we now have a clinical research collaboration across several countries in Europe, really trying to build a meta-analysis of long COVID across different countries in Europe. So one thing that we all recognize is that COVID-19, although a respiratory infection, really has an impact on many aspects of the body. So if we're then going to consider what long COVID is, we need to then have a multidisciplinary approach, and that's what we do. So we have a modular approach to the clinical care and phenotyping. So in our clinic in Leicester, but also being set up nationally, are then clinics that include input from a number of different disciplines, which go beyond the lung and include other organs, but also psychological support, physiotherapy, speech therapy, and this is coordinated through a multidisciplinary team effort. What we then have within FOSS-COVID is a series of working groups, and these working groups are then really focusing on the scientific questions that they wish to ask of the data set that's being collected. And as I alluded to earlier, this will include patient-reported outcomes, biological inputs, and immunology. And we're also very focused on involving patients and charities are then involved in each of the working groups. We're looking at impacts on ethnicity, and we're also introducing elements of social science and health economics. So on my last slide, our questions really fit into these broad aims. So what are the long-term consequences of COVID-19? And you heard many of those from previous speakers. And what are their mechanisms? And we feel we'll be well positioned to start to unpick that. What is the impact of acute interventions on these consequences? So interventions such as corticosteroids, do they alter the trajectory and consequences of COVID? And what other further in-depth studies are needed to then actually guide us in terms of further understanding, but also future interventions? And clearly within the study I've described, FOSS-COVID, what's going to be important is linking it to that broader landscape of understanding across how COVID affects people in the community, looking at a number of different approaches and different studies. Many thanks.
Thank you so much for this wonderful presentation. It was very excellent to see the integration into the service delivery models, and hopefully we'll have some time to ask more questions about this. So our next speaker, privileged to present Dr. Seong Ho Choi. She has been active in patient advocacy in women's health and doing patient-led research for over 10 years, coming from South Korea, and also the co-founder of the Long COVID Support Group. Over to you, Doctor.
Thank you very much. Hello, everyone. I'm Sung-ho Choi, an infectious disease physician of South Korea. Today, I would like to share with you COVID experience in South Korea. Next slide. As of December 6, 2020, 37,546 people were infected with COVID and 545 died in South Korea. The first wave of epidemic occurred in Daegu and Gyeongsang-Bukdo area through a religious group called Shincheonji. The second wave occurred around Seoul metropolitan area through political rally held in Gwanghwamun, Seoul, on the day of Independence Day in Korea. The third wave is now hitting the whole country because winter is coming and social distancing is not as well maintained as before. Next slide. South Korea is one of the countries closest to China where COVID first occurred. However, the COVID epidemic in Korea was not as explosive as other countries. People who had been in contact with COVID patients were tested and quarantined early. Social distancing was strongly enforced in the whole country. Most people wore face masks in all areas of everyday life. This in this picture, right lower part of the part is the Daegu Gyeongsang-Bukdo area, and the left upper part is Seoul metropolitan area. Most of the data on COVID patients in South Korea came from these two regions. Next slide. Here are data from 3,060 COVID patients in South Korea between January and March 2020. The mean age was 43 years, and over 90% of the patients did not require oxygen therapy. Since most patients were younger and there were relatively few severely ill COVID patients, there are still no studies on longer-term complications after COVID. Instead, in the next few slides, we will look at variable symptoms or complications of COVID patients reported in South Korea. In COVID patients, blood vessels such as arteries or veins may be blocked. Blood clots may form in deep veins of the legs, and part of the clots can fall off and block lung arteries, that is, of the pulmonary embolism. The following is a picture of the brain of a COVID patient with stroke, which is caused by the block in the large brain artery. A recent paper introduces 5 COVID patients with stroke in Daegu. Additionally, patients who surveyed after a long-term mechanical ventilation therapy may experience critical illness polyneuropathy, which is not associated with apparent changes in the brain. All of these neurologic problems may result in a long-term neurologic sequelae. Next slide. COVID may also cause changes in the heart, one of the most important organs. In severe COVID patients, myocardial damage can occur in 23%. As introduced in a recent Korean paper, in severe COVID, the ability of the heart to squeeze blood and expand afterwards was also inferior to those of mild COVID patients. Additionally, myocardial infarction or arrhythmia may also occur. Next slide. Decreased kidney function has also been reported, but it is less common than the instance of renal failure of Middle East Respiratory Syndrome or SARS. Next slide. Eye symptoms, loss of odor, or loss of taste are commonly reported in mild COVID patients. In a study surveyed through a questionnaire 1 month after treatment COVID, about a tenth reported that they experienced depression or post-traumatic stress disorder. Next slide. Despite these variable symptoms or complications, As you know, lung damage from pneumonia is the most problematic in COVID. Korea suffered a MERS outbreak in 2015. At that time, patients with MERS were followed up 1 year later to confirm whether the lung function recovered. Also, in the case of current COVID, follow-up studies for long-term lung complications are needed. Next slide. Recently, 16 large hospitals in South Korea started a study that regularly tracks COVID patients up to 2 years after the onset of symptoms with the help of Korean CDC. Through this study, changes in clinical feature, lung images, lung function, neutralizing antibodies, and cellular immunity will be investigated. This research is in the beginning, so it is impossible to show any results yet. I would like to share the ongoing result next time if I have a chance. Thank you for your attention.
Thank you, Dr. Choi, for your excellent presentation. And I think at this point, we're going to have the panelists, please, those of you who have spoken, please turn on your cameras. And I want to thank everyone for sharing such rich information, especially some of the early studies and descriptions of your patients and disease and the post-COVID characteristics that you have been observing. I also want to invite Dr. Nesreen Alwan to our panel as well. She's the Associate Professor in Public Health at the University of Southampton in the UK. And with that, I think we have time for just 2 questions. The first question is for Dr. Ivan Hung from Hong Kong. I think there was a little bit of an interest to see your opinion, I guess your perspective on whether or not you think your treatment protocol, or I guess your early treatment protocol in the patients that were admitted and hospitalized, since you admitted most patients early in symptom onset, if that impacted, you think, the development of prolonged symptoms or post-COVID, long COVID symptoms?
Yeah, it's a very good question. In fact, we have been following up our patients, about 500 to 600 of them, over the past, some of them up to 9 months already. And basically, we see very, very few long-term sequelae in our cohort. Patients who initially do have some fibrosis, especially those from intensive care on HRCT for the first 2 or 3 months. But by the time we repeated the HRCT in 6 months, most of them have almost a full recovery, which is very different from the SARS 2003 cohort that we saw. Many of them do have long-term sequelae on the fibrosis. For the COVID, I think the early treatment does help in terms of reducing the damage to the lung. Many of them, in fact, we expect a full recovery for those even in intensive care up to, I think, when you repeat the HRCT in 1 year. And functionally, they also have a full recovery as well.
Thanks so much, Dr. Hung, for that follow-up information. I think it is important, over time to see what over time, what happens to patients, is it 3 months, 6 months, 1 year, and what do we see as the limitations or functional limitations or other complications, how they evolve. So this is great work. I actually have a question also for Dr. Breitling. My question for you was about the integration into clinical service, wrapping up the follow-up of patients into the clinical service paradigm. And you discussed the long COVID clinics that are being set up around the country. And I was wondering, how are those being integrated into are they being integrated into primary healthcare centers? And how are you able to reach the primary care providers, which are going to be, in most cases, the first point of contact for a patient that may be suffering from prolonged symptoms?
Thanks for that great question. So guidance is being now given to primary care physicians in terms of how to manage patients with long COVID. And then that advice also includes suggestions around referral. And then what's then happening is then there's geographically spread hubs, which will then review those referrals, and then those patients will initially be assessed as part of a standardized process for long COVID. And then that will then lead to a further referral to specific physicians of different specialties if necessary. So it is joined up. It's taken a little bit of time to organize, but it's really coming together.
Thanks so much. I think that's one of the challenges. I think when we hear from the beginning, when the speakers at the introduction session, also the first session discussing about recognition, right? And that means recognition, you know, at the patient-clinician interface, and with the scope of the pandemic and the numbers of patients, you know, and primary care being a very busy place in general for in all unusual times during the pandemic, obviously increasing that burden. So how to get information out is hugely important. So I wanted to then just wrap up this session. I think this was a very informative session. So I want to thank all the panelists for sharing and for participating with us. And at this moment in time, hand off to, I'm looking at my paper here, hand off to the chair, that is Professor Piero Oliaro, Director of Science at ISARIC, and he will introduce the next speaker. So thanks, everyone.
Hello and welcome back everyone again for the next session. So we've heard so far what we're starting to appreciate about the breadth of what is now put together under this umbrella term of COVID-19, but by no means as yet as the depth of the conditions associated with this. And viruses are known to cause symptoms that could last and persist after the initial infection is gone. So what can we learn from other similar conditions? So now we are about to hear about another viral infection, which is known to have long-lasting invalidating sequelae. This is Chikungunya. It's a very different virus. It's a virus related to dengue and Zika. So the speaker is Dr. André Sequeira. He has been doing observational studies and clinical trials in malaria, but also on arboviruses like Chikungunya and COVID-19. And he coordinates REPLIC, which is a clinical applied research network on Chikungunya and emerging infections. Andre, over to you.
So thank you very much for the opportunity to talk a little bit about another viral infection which causes acute symptoms, but also has long-term consequences, in this case, chikungunya. So I'm going to talk a little bit about chikungunya as a health problem, some of the issues we have faced on the REPLIC, the clinical research network, how to measure and what to measure, establishing this harmonized multi-center study, and some parallels with COVID. So chikungunya is an alpha virus infection, so a very different virus, causing infections and mostly outbreaks in tropical areas, but also in temperate areas, as has been seen in Italy and France, for example. Its main characteristic is causing fever and joint pain, what's the most feared consequence, because around 40% of individuals, they can present with chronic arthralgia for longer than 1 year. And as chikungunya started to appear in Brazil, emerge in Brazil in 2010s, it was described to us as a post-acute rheumatoid arthritis-like disease. So we were expecting to see a lot of inflammation. But what we see, there's a lot of variation in the clinical manifestations. It's not a single phenotype of the disease. So we have patients with arthritis, with clear inflammation. Some have arthralgia that's more sort of mechanical. And some patients, they have severe pain, but there are no damage to the joints, but there is a lot of pain that's characterized as neuropathic pain. One of the things that we face, there's a large variation in estimates, and it's very difficult to compare studies and estimates from different studies. There is a complex spectrum of manifestations, so there's not a single phenotype. And one of the issues that is very worrying is that chikungunya patients with chronic symptoms, they enter in this circle that's from Professor Fabrice Simon in Marseille, of pain, stiffness. It impairs their usual activities. They gain weight, they have self-depreciation, depression, and it worsens the pain. So it's a very damaging infection and consequences. And most people, they suffer with that and they have no resolve from the health system. So this is a patient, one of the first patients that saw. She came with 18 months of arthralgia. And I just want to highlight this phrase. She told she was so depressed. She had 3 kids, but in time she looked at the window and he had this feeling of jumping. So I think it's the reason why we started studying the chronic consequences of chikungunya. When we decide what to measure, there are a lot of aspects. We can focus on pain, edema, physical capacity, but also social aspects, emotional, financial, and general health of patients. One of the problems we had on starting a study and how to be standardized is the lack of standardization in the evaluation. So this is a study of 5 patients evaluated by 20 different rheumatologists and how they assess the severity of each of these patients' disease. So as you can see, there's a huge variation. So how can you compare and see if the patient is improving or not? And here are estimates of chronicity, a systematic review made by Paixão in 2018. And you can see there's a huge variation. We estimate around 40% of chronicity, but it depends on how you measure, what are the inclusion criteria and the methods applied. So that's one of our worries. There had been some initiatives on trying to standardize and harmonize how to measure disease in rheumatology. So OMERACT and ISHON, we took a look at that. And then we established a multi-center cohort REPLIC, evaluating clinical, translational, therapeutic, and epidemiology aspects. These are some of the instruments we agreed on doing with physiotherapists, rheumatologists, and social scientists as well. and there are some challenges we identify as how to have rotation. If the patient has no symptoms, why to return? No treatment, why to return? And then they have to try to live their lives, have to have their earnings, how to evaluate some fine changes. We had to use sometimes ultrasound of MRI, and the waning post-epidemic financial, social, and political interests from funders, from health authorities as well, and lack of public management. So there are some similarities. I will leave it to the discussion. The time is short. And to thank all the participating centers. We are now conducting a study on COVID with collaborators and our funders as well. So thank you very much.
Thank you, Andre. This was a very interesting presentation of yours. I appreciate that it had to be short due to time constraints. But maybe just a quick question, since we are running out of time from me. So here we got a disease where the spread, the type of the pathology has been quite well defined, but the consequences can be quite severe in terms of, like you said, depression being particularly important, and what happens to these people in normal life. So how do you think what you've done, your experience that you gained with chikungunya, can help inform how we approach COVID-19, where the spread is much bigger?
Yeah, definitely. So when the COVID appeared, and there was the long-term consequences, there were some clear parallels for us. So one of the issues is to realize there are different phenotypes. So depending on how we measured and the sensitivity of the methods would alter our estimates. So for example, if you use ultrasound or MRI, we can detect some micro lesions that the clinician cannot see most of the time. And that we see a little bit on COVID when people have the symptoms, but they do CTs or other tests that don't detect it. And it's very frustrating for patients not to have, not to feel they are being cared of by the health professionals, because I don't know, we can't see nothing, so there's nothing, but people are really feeling, have the suffering from those symptoms. So these are some parallels, and also have community and public engagement and modifying what we are measuring as we go along, because we have added sexual health assessments that was not a problem in the beginning, alopecia. So for example, we are seeing more and more consequences as we progress in this study.
Okay, thank you very much, Andre. So I think that now we are going to have a break, a natural break for all of us. At the same time, there will be some additional testimonies. There will be patient voices, videos during this break. These are two people, two patients, Jen from the UK and Basha from India. They both have been living with long COVID now for months. Basha is also attending a meeting, and will speak a bit later on today. And they in these videos, they talk about their experiences, their symptoms, and also what they would like researchers to do about long COVID. So thank you very much, and see you very much. See you soon.
Hello, my name is Joni. I'm from Finland. I'm 34 years old.
Hello, my name is Konstantina. I'm 28 years old and I come from Greece.
I got COVID 256 days ago, so I have had symptoms last 9 months.
I fell ill with COVID in mid-April with dry cough, fever, chest pains and shortness of breath, which lasted for 6 weeks. At that time, I was taken to A&E twice where all the blood tests and x-rays came back clear, and therefore I was sent back home. Since then, I have been experiencing for the last 7 months the same ongoing symptoms: dry cough, shortness of breath, chest pains on the left side, and intermittent low-grade fever.
I have had about 40 to 16 blood tests. All came back negative. I had some testing in my lungs, checking the capacity. There is some problems with the capacity. It did something there, because this disease is so crazy. It's relapsing even on the first 3 months. You get the symptoms wax on, wax off all the time. Today I was in a quantitative test for a small fiber neuropathy, small fiber nerves, yeah. And I had some weird issues on my legs, in both legs. I don't feel the kind of pain hot sensation there. There is a lot of tingling and some weird numbness. I have issues in my forehead, in my cheek.
I've noticed that the symptoms vary from day to day, but they get dramatically worse after mild physical exertion, such as walking or hovering. Due to my health condition, I have been unable to return working face-to-face, and I had to extend my postgraduate studies. I've also had to move back in with my parents as I was unable to cope by myself.
It affects everybody, even you are 20 years old or you have basic health, you still can get long COVID. We have succeeded in some ways to get word about long COVID. There was a news documentary regarding long COVID at Finland, and it's shown in Finnish TV channel 5 for all people in Finland.
What I'm hoping and asking is for more research focusing on the underlying causes of those symptoms, which will potentially lead to treatments and ways of coping with them.
Please check my YouTube. I have tried to gather the information about long COVID from 16th of March regarding symptom vlog. I didn't know that it will last 256 days and still counting.
Hello, welcome again. This is Jean-Marie from EDSTP, that is the European and Developing Countries Clinical Trials Partnership. I'm based in the Netherlands. I'm supposed to be co-chairing with my colleague Annalise. Hopefully she will join. Now I'm going just to quickly give the word to Fernando Boza. Fernando Boza is from Brazil, works for BRICNET, and is going to talk about the ongoing studies on long COVID in Brazil. Thank you. Go ahead, Fernando.
Thank you. Especially thank you for the invitation, the opportunity to talk about the ongoing studies and long-term consequences of COVID in Brazil. I'm Fernando Boza. I'm a critical care physician. I'm based at the Oswaldo Cruz Foundation. Oswaldo Cruz Foundation is the largest and most traditional infectious disease research center in Latin America. And also I'm a member of the Brazilian Research Intensive Care Network. That is an independent network with more than 300 hospitals in the country, running observational studies and trials in critical care, especially now during COVID. We run 6 large trials, 3 trials published recently in Lancet, JAMA, and New England. Next slide, please. This slide is representing a comparison of the burden of COVID-19 per continent. As you can see, probably South America is the most affected continent in the world. Cases, but also deaths is really high in this continent. And especially Brazil is one of the most affected countries in the world with more than 6 million cases and more than 177,000 deaths. Then next slide, please. We are expecting a high burden of long-term consequence of COVID. Our group is working with long-term consequence of critical illness for more than 15 years. And we can see in this slide the concept that in reality, COVID and critical illness can share some similarities, but maybe COVID can have specific manifestations that we still need to learn. Next slide, please. At point of view of long-term consequence, what we learned in these last 10 years, we learned that survivors have high frequency of hospitalization, short and long-term high mortality, reduced quality of life, physical impairment, impairment of mental health and cognition, and also the families affected by this long-term consequence of the disease, especially at point of view of mental health. Next slide, please. However, we don't know many aspects of this long-term consequence of critical illness, especially mechanisms. Our model of disease usually is very related to acute damage, but we know very few about recovering and repairing. Also, we don't know very well what exactly is the burden of disease, what are the clinical aspects, and especially how to prevent this long-term consequence. Next, please. Now, what we are doing in Brazil, we are using the case report for ISARIC. We have included more than 3,700 patients in this prospective study, more than 200 patients with sequential samples using the Tier 2 Priority 5 protocol CCP from the ISARIC. And now we have started to follow up using the ISARIC Global COVID follow-up protocol. Also, we have some studies in this in the coalition, that is this BRICnet large collaborative initiative for clinical trials, where we have more than 1,800 patients included. And also we have an initiative that we developed some months ago that is a applet for test and track, with more than 1 million downloads and more than 47,000 patients tested, that now we are contacting these people by the applet and developing some surveys with these people. Especially in this figure, we can see some of the aspects of the ongoing studies, especially with focus on neurocognition, mental health, quality of life, but also thromboinflammation and lung aspects. Next slide, please. This is my last slide, and I will finish with this slide because I consider this a really important aspect. This is a recent comment published in Lancet last year about the long-term consequence of Zika virus outbreak. And they, in this comment, have some important testimonials from patients and doctors. And I highlight one specific from a mother that individuals and the government made a lot of promise, but now we have been forgotten. And this is the history for many outbreaks, that a lot of interest exists during the outbreak after the population is forgotten. I hope does not happen in COVID-19 survivors. Thank you.
Thank you, Fernando. I think my colleague Annelies Willer-Smith has just joined. Annelies, if you don't mind, please go ahead and introduce our next speaker.
Thank you, Jean-Marie. Can you hear me well?
Yes.
So my name is Annelies Wilder-Smith, and I'm Professor of Emerging Infectious Diseases at the London School and also work for WHO on COVID.
I think my colleague Annelies Willer-Smith has just joined. Annelies, if you don't mind, please go ahead and introduce our next speaker.
Thank you, Jean-Marie.
Hello again. I think again the previous speaker, and now I would like to introduce the next speaker, who is Professor Simone Piva from Italy, going to present about interest in delirium and inflammation, but also some other long-term outcome studies going on in Italy. Thank you. Go ahead, Simone.
Hi to everybody. Thanks for inviting me about the in this interesting meeting. So we carry out a study here in my city, and okay. So let me start my presentation with a clinical case. This is a Speed, 39 years old, admitted to our ICU with severe hypoxia. He was rapidly intubated and he developed a severe ARDS. We gave him a high steroid dosage and tocilizumab. He got supper infection in ICU, Aspergillus fumigatus and enterofacium. And he received, of course, multiple antibiotic therapy and immunoglobulin. So here is the impressive CT scan that we got on him. So it's a very, very severe ARDS. So in our center, we actually admitted 163 patients in ICU. And as you can see, some of them died, 55 in ICU and 15 in hospital. And we actually were able to discharge alive from the hospital 93 patients. We actually lost at follow-up 3 of them, and we were able to contact 90 of them. So we were able to perform telephone interview in some of patients, but 57 patients was in person. They come to the hospital for an in-person follow-up visit. So that's probably the unique study that patient has been seen in the hospital. So demographic characteristics, age 62, subsud 34, 10 ICU loss and 24 days hospital loss. So pretty much severe patient. 95% of them were intubated. So our follow-up clinic worked like this. So phone interview, blood work, and chest X-ray when the patient consent to come to the visit, and clinical visit. And during clinical visit, we actually explore this domain. Concerning physical domain, the only problem here, I'm talking about the pulmonary function tests, and actually probably the only one that were in some way impaired were the CO diffusion capacity, impaired in 7 out of 17 patients. Why 17? Because we perform the pulmonary function test just with the patient that has symptoms, sorry. On physical domain, MRC sum score, actually 97% of them, of the patient were normal, between 48 to 60. And the hand group dynamometry was more or less normal or above 60% in most of the patients. Interestingly, it was very interesting to perform a 6-minute walking test, because actually the percentage, the median was 450 meters with a percentage of the predictive of the patient report fatigue. In fact, they were actually 36% of the patient report fatigue when you ask to the patient to report them, and this is the fatigue FSS score. And we perform also electroneurography, simplified PENT electroneurography, and 35% of the patient were pathological. Cognitive domain, actually MOCA was pretty normal in 78% of the patient. No depression, no anxiety were reported. And this is very interesting. Just 3% of the patient report was really inexpected. Their sleeping profile were normal in 90% of the patient. Concerning quality of life with SF36, actually it was normal. Physical domain, 87% normal, and MCS, 100% normal. Bartle index was normal in 100% of the patient. So what we can conclude actually, first of all, that these results were not expected from us. And we got high mortality in our population, 42% for the emergency situation, but who survive have a good functional recovery. So our message is keep going. Sometimes the patient get very sick in ICU, but keep going. When they are discharged from the ICU, they do better. They do very well, actually. So let me conclude with this guy. This is the guy that I presented at the beginning. He is 39 years old. And he's a doctor, actually. And he was saying, I'm a doctor. I have never imagined to face death as in this case. And during these months, I had a lot of nightmares that I have been able to tell only to my wife. It has been a devastating experience, but now I'm able to appreciate many little things that I wasn't able to appreciate. And I did really want to see the birth of Alicia, my daughter, sorry, that gives me the power to go farther. I think it has been a little miracle, and what I feel is that I do not have anything to lose anymore. Everything in my life from now is just a gift. Thanks God. Thank you.
I will move further to the next speaker in this session, and that is Dr. Joseph Fokam from Cameroon. Joseph is, if he's already there, Joseph is a holder of an EDTP Career Development Fellowship, and he's a virologist working mainly on HIV in Cameroon before COVID-19. Now he's going to talk to us about the ongoing studies following up former patients or current long COVID patients in Cameroon. Thank you. Go ahead, Joseph.
Okay, thank you to everyone. I'm happy to be here as an EDTP fellow. So briefly, we'll be giving you some insight of what we have been doing as far as COVID-19 is concerned. So our center started testing for COVID-19 since April 2020 20, and so far we have tested about 12,508 nasopharyngeal swab, mainly from male individuals in Cameroon. So those we have tested so far, 2/3 of them are male. And we have tested across all age range. It is true the majority are those aged between 20 to 45 years, but everybody in Cameroon is quite concerned with COVID-19 testing. And now regarding symptom and testing, we have approximately 86% of those who were tested were asymptomatic. And this is because currently we have a growing number of travelers and also case contacts who are being tested without any apparent symptom. But it is not shown in this slide. We also have a series of symptoms that we have recorded among those we have tested so far. And we have, for example, the very first symptom we have is cough among our symptomatic cases, followed by headache. Then the third symptom we also have is like a running nose. Then we have also some few cases where we recorded chest pain or chest pressure. We also have difficulties in breathing. We also have diarrhea, and we also have other symptoms such as vomiting as well that we have recorded from those who were symptomatic. Then we now have a positivity rate of about 14% in this population, and this really goes across all age range, even though the rate of positivity also increases with advanced age. And in terms of viral load among those who were positive, we realized the viral load was extremely high during the first weeks of symptoms, which really goes with finding from the Western world, with a substantial decrease 10 days after symptoms onset. And when we look at the viral load according to the presence or the absence of symptoms, we now see in our context that the viral load was also very high among those who are symptomatic, in accordance with evidence found in the Western world. But what we didn't find significant also was the viral load according to gender. So when we look at male as compared to female, we realized the viral load was quite similar. So there is no difference in terms of disease severity or viremia according to the gender in our population. And we also look at the viral load according to the presence or the absence of symptom by age range. We realized the majority of those that had a high viral load were those between 20 to 35 years, but this difference wasn't statistically significant in our context. So meaning that the potential transmitters in our context will also be those who are within the age range of the active population. We also try to look at the evolution of SARS-CoV-2 according to the various months since we had our first case in Cameroon. And then we realized our very first wave was during the month of May. And actually, we are seeing a second wave coming after October. So we have a major risk of seeing a second wave in our context, maybe around the end of the year 2020, if no confinement measure is being put in place. Now, regarding the main concern for this forum, we tried to interview patients that got cured after a positive COVID-19 result. And then what we realized is that most of them had cleared the virus 3 weeks after infection. And those who had a delayed viral clearance were mainly those who had comorbidities, those who were also the elderly, or those who were receiving some corticotherapy. And we also realized some of them have a loss of antibodies some few weeks after infection. And we are also seeing cases of reinfection in this population. And what we have recorded so far, like complaints among those who were positive and are actually negative after being after suffering of COVID-19. It is mainly chest pain or chest pressure, and this was found mainly among those who had respiratory diseases or cardiac comorbidities. Then we also have prolonged tiredness that most of them have been complaining of, mainly those who are elders or those who have a diabetic condition. Then we also had one case of loss of consciousness in one of our patients. So we wonder if it was linked to the COVID-19 or if or maybe it was just a sporadic cases. Then what we also found is some HIV patients seems to be complaining more as compared to the negative individuals. So we wonder if it is linked to poor CD4 count or if it might just be a confounding factor. Slide. So we really wanted to thank all of our group that helps in developing this evidence, and mainly ISTP for providing us this support. And we hope to have the chance to really follow up these patients thoroughly to be able to ascertain some of these preliminary findings in terms of long-term effect of COVID-19. Thank you.
Okay, thank you, Joseph. Now we'll move to the next speaker, and that is Mr. Moses Badio. He is based in Liberia, working for the Partnership for Research on Ebola Virus in Liberia, PREVAIL, known as PREVAIL. But he's going out to talk about what is going on in terms of observing long-term patients who have experienced COVID-19. Go ahead, Moses.
Okay, thank you and sorry for the delay. Okay, so my name is Moses Badio. I'm working for the Partnership for Research on Ebola vaccines in Liberia, PREVAIL. So just a little background, PREVAIL is a clinical research program that was established during the 2014 or 2016 Ebola outbreak, and has since been involved in clinical research and trial and observational studies of other infectious diseases. So basically, I'm going to present what we are doing as it relates to COVID-19 observational study in Liberia. Next slide. So just a little background about Liberia. So located in West Africa, Liberia is estimated to have about 5 million people with a very fragile health system. Doctor to patient ratio about 1 to 15,000 estimate from the Ministry of Health. So like most other African countries, in Liberia, there appears to be a more mild symptom and less severity of COVID. And as of December 1st, there were about 1,500 confirmed cases, including 83 deaths reported according to the WHO situational report. Next slide. Okay, so our study that we call the PREVAIL COVID-19 Observational Study, PCOS for short, is a two-phase acute and a long-term follow-up phase cohort study with individual tested positive for SARS-CoV-2 and their close contact who test negative after exposure that we will use as the comparison group. So we intend to enroll around 500 confirmed cases of COVID and 1,000 contacts who test negative. So we are going to follow them up during the acute phase for up to 28 days. And also during a long-term phase, we intend to follow up our participants for up to 3 years with a 6-month interval. Next slide. So I'm just going to focus on the long-term phase. So the primary objective, due to several research gaps, we intend to characterize and compare those tested positive and negative contact from baseline through 3 years of follow-up with regards to their health status. We will be looking at neurological, respiratory, gastrointestinal, cardiovascular, for example, through the 3 years of follow-up. And we will also evaluate the rate of reinfection in cases, those that were initially infected, and we'll look at new infection in those who enrolled in the study as close contact, and immunologic response also to SARS-CoV-2. And there are several secondary objectives. So our study will enroll children. So we evaluate the same primary objective in children, and we intend to compare symptomatic cases and those who enrolled as control with regard to genetic and immunologic characteristics. Next slide. So we also intend to evaluate self-reported health status at baseline through the follow-up period. We will be looking at post-traumatic stress disorder, including depression from baseline through 3 years of follow-up. And we have an exploratory objective that is to compare the outcome of what we see in our study with what is happening in other international studies, that is the INSIGHT studies. So we are collaborating with this global network. Next slide. And the significance of our study, we think this study is going to address a lot of gap currently that we are facing in terms of COVID-19. So we intend to understand the lack of, we intend to know the lack of understanding of genetic impact on both acute and long-term clinical immunological implications of COVID-19 in a Liberian population, as well as other places that could be related to Liberia, or specifically to understand why there appears to be a more mild symptom and less disease severity in Liberia as compared to other parts of Africa. And lastly, our study will document the long-term sequelae of COVID-19, including reinfection and evaluation of antibody response in our population. So we think with all of the complications currently, we are going to provide some significant findings as it relates to what we will be doing in Liberia that could be useful to other places in the world. Thank you. Over back to the presenter, to the moderator. Yeah.
Thank you, Moses. Now we'll move ahead to Professor Danny Altman from the Imperial College, UK. Altman will be giving us a talk about immunology aspects in the context of long COVID. Please go ahead, Danny, if you are ready.
Hello, can you hear me?
Yes.
Yeah, great. So good afternoon. So I don't know about you, but I've learned an immense amount today. And I've also learned an awful lot about long COVID in the last several months, speaking to people with long COVID. I come at the question, I guess, from a very sympathetic background. You've already heard from Andre Segura from Brazil today, and we're co-PIs on an award that aims to look at underlying mechanisms in the immunology of the sequelae caused by Chikungunya virus. I'm also an immunologist who's spent the last many decades kind of straddling the world of infectious disease and autoimmunity. So it feels like a very kind of natural place for me to be. So just by way of introduction, when I look at what's going on at the moment with long COVID, my guesstimate is that we probably have way more than 5 million people on the planet now with long COVID. And the lesson I think one can pick up from things like that Chikungunya experience are that actually long after you've perhaps dealt with your acute infection, or maybe even have some good vaccines, the legacy that the virus leaves behind can actually be a far more desperate burden for the sufferers and for your healthcare system than the acute infection that triggered it. And I think that's real food for thought. I think the other thing that I get when I listen to the testimony from the people who've been at this meeting is that it's fine to have observation, and we certainly need to kind of identify and record the phenomenon, but our observations aren't much good to them unless they lead to some mechanism, and unless that mechanism leads to some intervention that actually helps people. So I guess my take on this is that it's all about trying to understand the pathogenesis. And again, I think coming at it as a professor of immunology, to us, things that seem very confounding in long COVID, like how can you have a pathology that moves sequentially around the body? It means you have to see doctors from different specialties and different clinics. That's very familiar to us from a disease like lupus. Or if you ask, how can there be a disease that has these bizarre relapses and remissions, flares of disease, sometimes triggered by stress? That's very familiar to us from something like multiple sclerosis. So it's a language that we're used to talking, and I think it's a language that we can bring to bear on the problem we're about today. So have the second slide, please. We on to it? Yeah. So we don't need to talk a lot about the basic immunology of COVID-19, except to say that I think as we think about long COVID, we need to understand two parts, or at least two parts to the story, don't we? The immune response to the virus, and then whatever immune or inflammatory dysregulation follows on from that immune response to the virus. So I won't go through all the bits of this slide about immunity to the virus, but it's one that I've been working with and playing with in various presentations probably for 6 months now. And the questions that seemed paramount 6 months ago, in a way, still seem paramount now. Trying to work out the correlates of protection and the impact of cross-reactivity from the closely related human common coronaviruses, and really, what does long-term protection look like? So we won't dwell on that now. But let's go to the next slide, please. If we look at the other part of that story, I said that I think we really have to promise to deliver on some kind of intelligent investigation of underlying mechanism and pathogenesis, so that we can dig into that kind of immunological toolbox of therapeutics and work out how to help people. So certainly when I apply sort of everything that I've ever learned about these diseases to long COVID, I come up with all the obvious that I think people at this meeting have all thought about. Is it to do, or does it involve the actual antiviral immune response, or the consequence of an inappropriate antiviral response? Some papers and some people think it's a consequence of too little antiviral immunity or an inadequate response to the infection. Some people believe that they have evidence of too much immunity or inappropriate immunity, or a hyperinflammatory response that fails to wind down properly. A variation on that theme would be that as a consequence of infection, one sees, if you like, a kind of hand grenade thrown into the normal immune subsets of the immune system, and they're disrupted and might take months or years to re-equilibrate. What about the actual consequences of persistent infection? Once upon a time, I would have said that would be impossible for coronavirus. But as we've learned week by week as scientists, everything that we said was impossible last week turns out to be a fact this week. And of course, people would have seen papers on PCR-able virus from stool samples and from colon. Or what about the consequences of viral infection triggering a bona fide autoimmune response, and many examples of that in terms of things like Epstein-Barr virus and MS, chikungunya and arthralgia, and from the PREVAIL study, actually, that you heard about a few moments ago, Ebola virus and post-Ebola syndrome. So if I go to the next slide, please. Yeah. So the other kind of part to this story is sort of concern about what happens during the period after acute COVID infection. And one of the things that we now know happens more and more is reinfection. And that, if you like, is one of the consequences of that proportion of the population who make a very poor response when they first meet the virus. And this is part of another collaboration of ours with a group in Brazil with Professor Roque Almeida in Sergipe, describing a cohort of 30 healthcare workers in one healthcare center who go on to become reinfected a few months after their first infection. And actually, that's correlated with very low antibody titers. And some of them get it more severely, and one of them goes on to die, unfortunately. Let's go past the next slide, because we've talked about Ebola and the PREVAIL study. So this is just to remind you that we know how to narrate stories of viruses as etiologic risk factors in autoimmune disease. If you take the example of multiple sclerosis, and so I'm not making a literal parallel here, because obviously they're very different viruses, but we have tools for looking at this. Can I have the next slide, please? Part of that is a story told in terms of the diversity of the T-cell repertoire, which is something that we and many other T-cell immunologists in the world have been looking at in great detail. Let's go past the next slide. Yeah, and next one, please. Yeah, so just to try and finish up, I don't can run over time, but this is part of a paper with many co-authors on it, who I won't name now, but it will take too long. And this is our take on looking at T-cell and neutralizing antibody responses in the consequence of so-called mild COVID-19. And if we go to my last slide, it's to remind you that this has been a very confounding disease, kind of with a story narrated in real time on a scale that we've never ever unraveled a story on planet Earth before. And everybody you look at is a bit different. So at the top of that slide, you've got people's neutralizing antibody responses to the virus. T-cell responses to the virus. Below in the black, you've got the neutralizing antibody responses, and that's simply a cohort of healthcare workers, and they're all different. So that's the kind of let's take let's get rid of that slide. That's my last slide, I think. So I just want to leave you with the idea that I think we all face the challenge of unraveling this complex pathogenesis in a species, humans who are horribly diverse and heterogeneous and all tend to do things differently and respond differently. But I think the challenge we've got as soon as possible is to tell the story of this pathogenesis so that we can do something about it. Thank you.
Thank you, Danny, for remarks. Now, I just would like to welcome back Claire Hasty and Andre from Brazil, who will help us go through the last few questions. But just because we have limited time, just 1 minute for Claire to make a general comment based on what was just presented in this session.
Hi, thank you so much for this. I'm so excited by the amount of research that's going on all around the world. It really is. As a patient, I'm part of the long COVID support group of 31,000 people, and it is wonderful to hear about it all. I just want to emphasize the importance of community cases and researching community cases as much as possible, because I know that in a lot of countries, those who were admitted on the basis of thresholds to do with things like oxygen saturations and the particular presentations of their illness. And many of those who came and knocked on the door of accident and emergency departments multiple times were turned away for that reason. But I think our symptoms are also very severe and very debilitating, and across diverse systems. So please, research community cases also. We are very, very happy to help. We'd love to be involved in the research involvement side to make sure that some of the findings that come out ring true to us. So thank you.
Thank you, Claire. We have a lot of questions, so I hope the audience will understand as if we cannot cover them all. Hopefully the conversation will continue on Twitter and other media, but I'll just pick a few questions that are coming. One maybe to Danny. People who are with long COVID but with negative antibody tests, do you think they should be prioritized for vaccination? That's a question from the audience.
Yeah, no, it's a question that I hear a lot. Obviously we have lots of priorities for vaccination, and there's different cases to be made. But I certainly think that people with long COVID should come forward as soon as their countries allow for vaccination, because certainly nobody wants to go through a reinfection. And like for everybody else, I think the vaccines are the answer.
Okay, thank you. I have another quick question I'll go to Moses. Moses, it's a question related to stigma. We heard earlier a presenter from India talking about stigma. Maybe in Liberia you have the same cases. Now, how can studies in low and middle income countries deal with long COVID research, considering the stigma in the community?
Okay, thanks for the question. So we intend to evaluate stigma and discrimination of those infected with COVID as compared to those who were not infected in our study. So stigma is a major issue in infectious disease like COVID, but we think that as we evaluate stigma, our study going to actually provide a lot of information on what kind of a stigma that people face with COVID and how those kind of issue going to be addressed. I think our study will address that. Thank you.
Thank you. Then the next question, which I'd like to send to Joseph. Joseph, I know you work a lot on HIV and now you've been dealing with the COVID. And there's a question about how can different disciplines or different areas work together to kind of work on long COVID, but also considering the impact of HIV and TB, for instance, on COVID or vice versa. What do you see as a way forward if you consider your setting or in general?
Yes, thank you, Jean-Marie. I think in our context, being an HIV center, we use our HIV experience to leverage on COVID-19 response. So what we have been seeing so far among patients who are HIV positive during this period of COVID, there was really a slow turn down in terms of hospital attendance and in terms of treatment monitoring among those who are HIV positive. But what we didn't see really is how COVID or HIV could really have an impact on each other. There wasn't really an issue with maybe mortality severity among those who were HIV positive as compared to the negative one with respect to COVID-19. So what we think will be very important is not really COVID-19 with HIV co-infection, but it will be what would happen for an HIV patient after recovering from COVID-19. Because most of them have recovered in our context. We have a very low rate of case fatality rate, which is like less than 2%. So our major concern is after COVID infection, what happened with an HIV patient? Does it mean those who have poor immunity seems to have a slow recovery after being infected with COVID-19? And essentially what we are seeing for those who are HIV positive, it seems like they tend to have a slower immune recovery after they have suffered from COVID-19. So these are really preliminary observations. There is no significant difference. And that's also why we think there is really a need to do a kind of long-term follow-up for those who have recovered from COVID-19. For TB, we don't really have a lot of cases that we have reported so far. It is mainly for those who are HIV positive. Thank you.
Okay, thanks, Joseph. And maybe this other question is for you. The testing capacity is a bit low in many countries in Africa. And some of the members of the audience are wondering if you consider rural areas, for instance, there maybe it's much lower. And the question is, how will that be factored into research, especially if we want to make long COVID research generalizable on a country or continental level?
Yes, I think in Cameroon, what we did at the very early stage of the pandemic was to also implement molecular testing in 9 out of the 10 regions of the country. So that really helped in terms of detecting positive cases. But also we realized the rural setting was still underserved. So we put in place at the very early stage of the pandemic antigen rapid testing. That really helps in detecting those high viral load cases within the community. So by combining antigen rapid testing, and not antibody, and PCR, we were able to really to pick up most of the positive cases in our community. So I think the way forward for low-income countries like Cameroon, it will really be to implement rapid antigen testing in the rural settings, and while using now PCR within the reference facility to really maybe answer those key research questions.
Thank you. We have a few minutes, but I'll just go to Fernando and direct a question there about treatment protocols. People are wondering if there are treatment protocols available for long COVID patients, or if that is something you'd like to see developed, and if yes, by who, if there has to be a general treatment protocol.
Jean-Marie, thank you for the question. It's a trick question. In reality, no, we still don't have any treatment established for long-term COVID. But for other side, we know that several sequelae, especially for critical illness, can be managed in different ways. We still need to think about prevention, because probably we can do much better, especially for severe patients in ICU and hospitals, and several other aspects, especially relate to impacting the family, subestimate in general, and especially in this moment where the families cannot visit patients. We know that the visitation hospitals improve or reduce PTSD in family, for example. Then we can do several things to engage families in the care, or at least to have information, also how to establish early physiotherapy or rehabilitation for these patients, and especially at the cognitive point of view, especially for old patients. We know that long-term outcomes, dementia, especially related to delirium during hospitalization, it's a major problem. Then we can also to prevent. In my point of view, really we need to, in this moment, to think about how to prevent sequelae, and also how to estimate the burden, and maybe before also to have good treatments.
Yeah, thank you. Maybe just one last question for both Simon and Andre about the patients that were not seen in hospitals, those who were not hospitalized, but maybe remain away from the radar. How do we ensure, or based on your experience, are those patients being considered in research, long COVID research? First, Simon.
So what I can tell you is that we analyzed 430 patients that was discharged from the hospital and not in ICU, and they were not in ICU. And actually, also in this case, I can say that they feel very bad. But when they when we visit them, well, actually the physical examination is quite good. And on the other side, on the 93 patients that we admitted to the ICU and they did not come to the follow-up clinic, actually most of them, they didn't come because they feel very good.
Okay, thank you. Maybe
So
before I hand over, if Andre can just say a few words in 10 seconds, what we can learn from Chikungunya in terms of following up patients.
Yeah, I think one of the words of patients is to define what they have. So if they weren't tested in the acute phase and serology is not always trustable, having some clear definition and answer what they have and what they want to have a diagnostic. So diagnosis and be treated a certain way. So I think this needs to be harmonized and worked on.
Okay, thank you, Andre. And now we are over time, almost just on time. I'm going to hand over to Gail Carson to wrap up the session and the program of the day. Thank you.
Thank you very much. Thank you very much, Jean-Marie. I'm Gail Carson, one of the directors at ISARIC and GloPID-R Scientific Secretariat. On listening to you all over the past 3 hours, I've been really actually moved by listening to the people living with long COVID describe how isolated, how alone they felt. And my goodness, if there was ever a reason for us to come together as the global scientific community and public health, and indeed the governments, to try and support our people going forward, there was never more of a time needed than now. Is this actually going to be the pandemic of 2021? I think listening to some of the points that were made about the need to integrate that holistic approach to care across primary care, the community, as Claire highlighted, into the hospital if there were patients were hospitalized, or to remain in that community, but never, ever, ever to feel as though you're completely alone, that your community has forgotten about you because you are physically isolated, perhaps in a lockdown or like situation. But Dr. Tedros was here this morning, the head of the World Health Organization, and he's already heard you, and he's heard you again, and so have we. The research community, the research funders, we've had participants on this call today from a number of governments around the world. And we're all listening to you, not to mention a number of national public health agencies. So thank you all to those who have participated, who we're all going to try to work together to understand, to characterize what is long COVID really. How can we try and manage it? How can we try and better help you and your symptoms? But I think we must remember we have to also try and prevent each other from catching this infection in the first place, and that will take a community-based effort. So looking forward to seeing you tomorrow. We will have some super talks again tomorrow, along with people living with long COVID. They really have made this meeting, I think, work. Listening to them has been so critical. And we will include some mental health issues tomorrow as well. So thank you very much. It's been an absolute pleasure. Take care, everyone. Goodbye.